Hi, Dr. Stanley here, and today we are looking at another quick medication fact with sleep-related medications. Now, when we are looking at sleep-related medications, we should understand that in psychiatric nursing, this is something that we are frequently required to deal with because of the fact that many of our patients are going to present with sleep disturbances. In fact, we may see people who their mental illness symptoms are either brought on or quite exacerbated by problems with sleep. So, first of all, we're going to talk about the non-benzodiazepine receptor agonist or Z hypnotics. Remember, we've already had a segment on benzodiazepines in our teaching series, so you can feel free to go back and watch those, and there should be some information there on how benzodiazepines can affect sleep. So, we're not going to cover that in this particular video, but we are going to talk about these non-benzodiazepine receptor agonists or the Z hypnotics. Now, these are short acting and they are sedative hypnotic agents. And unlike the benzodiazepines, which also have anti anxiety properties and muscle relaxant properties and anticonvulsant properties, these really only have the hypnotic and the amnestic effects that you see with some benzodiazepines. So they're going to be more selective with the GABA receptors that they target, and it's going to be the ones that are found on the alpha 1 subunit. Now, they can still cause sedation, just like benzodiazepines, of course, and that is, of course, the goal when you're trying to treat sleep. They can still cause the ataxia, which is the alteration in movement where you have problems with muscle coordination. And they obviously are going to still produce harmful effects for the elderly and can lead to falls, fractures, and delirium. They are still controlled substances as well, but they have less tolerance that develops and a little bit less risk for dependence than you're going to see with benzodiazepines, but they do still have some risk. So you're not going to have that tolerance, meaning that it takes more and more to do the same thing and to the same degree that you have with benzodiazepines. And you're not going to have that dependence to the same degree either, so they're not as much of an abused drug as a benzodiazepine might be. They do have a shorter half-life than benzos, and they have no active metabolites. Now, so here are the specific meds that are related to that. First of all, we have zalaflon, which it has a short half-life of about an hour. So obviously, if you only have an hour worth of half-life for the medication, this is not something that's going to keep you asleep all night. But for some people, they have trouble falling asleep, but they don't really struggle with staying asleep. So this can be the perfect medication for them. It does metabolize more slowly in women, and so you are going to have higher blood levels in women that are going to occur of this substance. And so the FDA has recommended that when you are starting individuals on this medication, that when you have a female patient, that you do lower that starting dose for this particular patient. Now, I don't even know how to pronounce this one, but esopiclone is a 6-hour agent, and it's for people who need help staying asleep. And so this is one that is a lot longer than the Zalflon, which is going to be, something that's going to be very short acting. This is going to be longer acting. And so if somebody has trouble falling and staying asleep, this is the drug of choice for the medication of choice for them. Now, I want you to know that there are some problems with these medications. And so I always like to tell a story of my friend who was out on a boat with his son, and he said to his son, I'm going to go down in the bow of the boat and I'm going to take my sleep medication. And so his son was like, all right. And about 30 minutes later, his dad comes back up and he goes, hey, safety check. And he dives over the boat into the water, and his son has to wheel the boat around and fish him out. And he wakes up the next morning. He's like, what happened? And he's like, do you not remember that you just woke up and came up here and dove over the bow of the boat? And he's like, no, I have no memory of that. So that's an example of a complex sleep behavior. So you can imagine that if you're diving into the water off a boat, or you're driving your car, or even cooking at night, or sleepwalking, or eating, that you can actually have some dangerous behaviors. And these behaviors can result in your harm if you are having these complex sleep-related behaviors. And these behaviors do occur when the patient's not fully awake, and like my friend, they may not remember the event. Incidentally, this is going to be something, again, that is going to be potentiated by the use of other central nervous system depressants. So if you had somebody that is going to be drinking alcohol and they're taking the medication as well, This could be something that could be very problematic for that individual. So, obviously, these meds are going to be contraindicated if there have been previous complex sleep behavior incidents. So, if a person has a history of sleepwalking or something like that, they are not a good candidate for this kind of medication. Now let's talk about melatonin receptor agonists. And of course, melatonin is a naturally occurring hormone that is produced by the pineal gland, and it's part of the normal circadian rhythm of individuals. But we do have some things that are going to help with that. So we have one medication known as Ramelteon or Rosrem, which is a melatonin receptor agonist. And it works for insomnia when people have the difficulty falling asleep. The good thing about this one is there is no substance use misuse potential. So when you have somebody who's had a use disorder, this is going to be something that might be effective for them, but that is not going to have that potential that it could trigger them or cause them misuse of the medication problems. It does have some side effects. It does have dizziness, headaches, decreased testosterone, and with that, it's going to cause some sexual side effects such as loss in interest or even problems with fertility. And it does interact with fluvoxamine, with Prozac, which is, I'm sorry, that's not Provax, that's Luvox. And so it's going to be contraindicated when you have somebody who's on fluvoxamine. Now let's talk about one of the most frequently prescribed sleep agents, which is trazodone, also known as Desaril. And this is actually an antidepressant in its class, but interestingly, it doesn't function that well as an antidepressant because the amount that it would require to allow for a remission of symptoms would actually probably kick someone into serotonin syndrome because it's a pretty high amount. So they don't really use it for depression, but they use it more for sleep. It does have significant sedative effects, and it does help with some of those depressant-induced insomnia problems that are related to the fact that, antidepressants give restlessness and things like that and can induce insomnia. And it can, of course, cause sedation, which is what we want. But along with that, there is this drop in blood pressure that comes, that orthostatic hypotension or hypotension that occurs. And there is nausea that can also occur. So you can imagine that with elderly individuals, the hypotension might be a real problem when they're getting out of bed at night to go to the bathroom. It is going to be contraindicated in someone who's had a recent heart attack or has a QT prolongation, either related to maybe a electrolyte imbalance or some other factor. And it's also been known to cause priapism. And priapism is a condition where someone has an erection that is sustained due to blood flow in that area for an extended period of time and it doesn't drain off. And I've actually had a patient that experienced this while I was working on the unit one day, and we had to send him to the emergency department in order to have the blood drained off. So this was something that was extremely painful for him, and he was a fairly young patient as well. So even though these don't occur very often, these types of side effects can be related to the administration of trazodone. Doxepin or Silanor is also a low-dose tricyclic antidepressant, and it is proved for difficulty staying asleep, that type of insomnia, but it doesn't help too much with the sleep onset. With the administration of this medication, we want to avoid MAOIs, and anybody with urinary retention or glaucoma problems should not be prescribed this medication. It is not a controlled substance, which does help because, again, it has a low misuse potential. And we also want to talk about orexin receptor antagonists. And orexin is a hormone that's released by the hypothalamus, which promotes wakefulness. And so we have Balsama and that limborexant, which are orexin receptor antagonists, and they block both orexin receptors and they suppress wakefulness as well. And so these are really good for insomnia that's characterized by difficulty falling asleep or difficulty staying asleep. We don't see those quite as often as we do some of the other medications in the psychiatric unit, but they are out there. They are a controlled substance and they do have a potential for misuse. And some of the rare side effects are sleep paralysis, hallucinations on awakening and falling asleep, and cataplexy-like symptoms, which is a loss of muscle tone prompted by strong emotions such as laughter or surprise. And you'll understand when we talk a little bit more about narcolepsy how that can be a symptom of narcolepsy as well. And so obviously this would be contraindicated in patients with narcolepsy. Orexin-containing neurons are diminished in narcolepsy, and that is the reason for that. So anyway, I believe that this concludes our sleep medications and kind of gives you a quick down and dirty overview of the sleep meds. So please consult your book for any further information, and that is all.